I want to talk a little bit about how our research and the kinds of things that we've been doing, because I think that innovation is a way for us to provide better care and take better care of patients. So for me, it's not so much about that, it's really about the patients. I do have some disclosures, I have them here so that you can see them. So I know we've had an intense day of research data presentations, but you know, the reality is until Cosmos says that there's a millennial problem for STIs, it's not real for our patients. And so it's significant because, you know, STIs, despite the fact that we all sort of care about these issues, they're not very sexy. And the reality is that 1 in 2 young people will have a STI before their 25th birthday. And I think that that's something that's both preventable, and if it does occur, there's something we should be able to do about it. And the other issue is I've been very influenced by these IUSTI meetings. Several years ago in Malta, I heard a debate between 2 people, and they were debating this notion of healthy sexuality. So I've sort of co-opted this thing after hearing Kevin Fenton give his side. So it's a little odd for a pediatrician to talk about having people having a healthy sexuality and good sex. But the reality is that I've come to believe that. And so the reality is people should have consensual sex, which is a hot topic right now in the United States. That it should be unimpaired, which is also a hot topic for us. But mostly that it should be safe. And I think safety was the issue that they were debating and how that presents itself. Further reality for me is I work in a place where sexually transmitted infections are common. And so when I hear people talk about the numbers, they mean a lot to me because our local data is very powerful. At the same time, I'm not sure, but at the same time in that debate, I remembered that they talked about people having this sexual freedom, and that it was all about sexual freedom. You should be able to do what you feel, and that IUSTI, and there's going to be no control over that so that people could have that freedom. But I'm not sure that my patients, I remember sitting there, my patients who live in high SD prevalent communities have that same kind of sexual freedom. And I think that this group in particular is part of our role to sort of try to help that be attainable for everyone. And so I think a lot about what we can do to promote that. I'm also very conscious that about 65% of the patients in our community, probably more than that in our research studies, people who really contribute to the work that we're learning from, probably more upwards of greater than 80% of them are African American women. And the data actually have demonstrated over time that from birth, the reproductive potential for African American women in the United States is diminished. And there's significant health disparities. And for me, disease status is one of those things that has profound impact on it. I actually switched my professional career from doing hormonal research for women who had menstrual disorders to working with women who had sexually transmitted infections because of its impact on their reproductive potential. Because we did the research and we asked them what was important. So I spent the other one half of my life convincing people that sexually transmitted infections are important, and the other half trying to convince them not to get pregnant until it's time. But the reality is that when we ask young people, male and female across the board, how important is it for you to be a parent in the future, 90% of them is somewhat or very important. And so that's another key aspect of our role, I think particularly for those of us who take care of them so young, is that we figure out ways to be preventive but also intervene. So most of my research has been on pelvic inflammatory disease. I didn't show all the sort of prelim sides to how we got to this point. Just trust me, it was on PID before this. And the reality is that I did some work with the PEACH trial data, which is large randomized controlled data, has more national prominence. And we really demonstrated that while we cut back on care for women in the United States who had PID based on that study, women didn't have great outcomes. 43% of women had chronic pelvic pain, 21% had recurrent disease, 19% had issues with their fertility. So those things really exist in the data when we reanalyzed it. We also know from our data and other outpatient data that people don't do well in the outpatient setting. They don't adhere, they don't take the medicine for 14 days, they don't come back for follow-up care, and it's cheap. Because low-income women don't come back for fertility services because they can't afford it and it's not covered on their health insurance. And when they don't come back for care, that doesn't cost the healthcare system. So in the economic analyses, they don't count. And so for me, I want them to count. And so I thought we needed something that certainly not as expensive as randomized trials all over the country with like doing that. But I thought we should spend a little bit more money on women to try to find something a little more effective. So I started with this community health nursing approach. So it's sending nurses out to do the work of that 72-hour visit that we couldn't get people in. About 25% of people come back as the CDC recommends. But the NIH didn't think that was innovative enough. So we added a technology component to it, and so we text women reminders about their appointments and to take the medicine every day. And so this is the study, which is the Technology Enhanced Community Health Nursing Study, which is a relatively large randomized controlled trial of based on the integrative model of behavior, where we send women text message reminders for on how to take care of themselves post-PID, but we also send the community health nurse out to do the care that they would get in the office that they're missing. We use a CDC sort of approved intervention that's been effective for similar populations because we want them to respect themselves, protect themselves, because we know that they're worth it. And we actually found that we had, in this study, we recruited 292 women. And even though these are people that folks would never enroll in a randomized controlled trial, they're mostly young people, mostly teenagers, mostly low income. They are notorious for not coming to their clinic visits on time. But we retained 95% of our sample over the 3-month follow-up period in our intervention. So just for the CDC recommended follow-up, our intervention is 86 times, women in the intervention are 86 times more likely to receive that care than the women in the standard of care control group. We also demonstrated that we could reduce the time their STI positivity, gonorrhea and chlamydia positivity over time. So TECHN participants actually experienced a 28% decline from baseline STI positivity compared with 14% in the control group, and that is statistically significant. I think the issue is that one of my colleagues and collaborators here said, oh, let's just test them for some more stuff. You know, it's not required. Let's send some trichomonas and some mycoplasma, even though mycoplasma wasn't even an STD for the United States government at that time. So we have all this other data on our patients, and what we found is that that syndromic management that we were using to take care of those patients didn't cover them sufficiently for PID management. And so as you can see here, you don't really see a change in their trichomonas status over time or their mycoplasma genitalium status over time. And that is a real issue for me. So in the middle of our study, mycoplasma genitalium was added to the CDC guidelines, but there are no screening recommendations and there's no commercial tests. So it doesn't really do anything for the general population. With regard to Trichomonas vaginalis, it's an old infection. It's been around forever. But antibiotic coverage is optional. So Flagyl as an additional adjunct medication is optional, but it's also difficult to take with doxycycline. It makes you feel bad. And if you're a teenager and your parent is not managing that care, it's super hard for you to take. And so they don't take it. So it's harsh. But then people say, oh, those women have PID. That's a very specific population of women. So we decided, well, let's see what's happening in our general clinics. And so we developed a study where we looked at women in adolescent clinics and pediatric and adolescent clinics and OBGYN clinics who were seeking reproductive health services and who were going to have STD screening that day for gonorrhea and chlamydia. And what we found here is that 15% of our sample had mycoplasma genitalium. We had another 9% who had Trichomonas vaginalis, 8% had chlamydia trachomatis, and then we had only just a few women, 2% or 1% who had Neisseria gonorrhea. What's interesting is that people always talk about mycoplasma, at least to me, is this sort of co-infection, this pathogen that's sort of just hanging out, you know, kind of like us all tonight, making friends. But the reality is that they appear to be, in this general population sample of non-PID affected women, a separate subgroup, because we see co-infection of about 2% amongst individuals who have chlamydia and 2% amongst individuals who have Trichomonas vaginalis. So it's not necessarily a co-infection for everyone. The other thing I'll say is this study really represented to us that women want to know their results. So now we've recruited about 750 women for this study. 37% of those women are pregnant. And we recruited them all with just the offer of the testing, offer for treatment and follow-up, and paid them no remuneration to participate in the study, which is unheard of at Hopkins and in Baltimore. We also have the tech-in data, and we looked to see, so we were able to wonderfully have access to some resistance testing as well as some in-house testing, and really compared the SpeeDx with some of the other testing and found it to be comparable. But the big issue for me here is really that almost 65% of the patients had macrolide resistance. So it suggests that not only do we have an issue in terms of diagnosing people, but we have a problem with regard to making sure that people get the right medicine. So the dilemma really is that there's no public health control program in the United States for mycoplasma or trichomonas. Recurrent and persistent infection with mycoplasma and trichomonas is associated with ongoing infection in the female genital tract. Microbial shifts in the compositional biology really hinders the growth of what people consider healthy bacteria or vaginal dysbiosis. And there's increased risk for secondary STIs and HIV. So we're already a hub for those things, and so now we're not treating women or testing them for these issues. And there's really no studies or interventions to address vaginal health using precision care in a population like ours. And you know, when we think about it, most people are focused on your gut. They want you to all eat yogurt, but nobody's really thinking about the vagina. Only about 2.9% of studies in the world actually focus on vaginal infections at all. So for me, I think that we now are moving to an era of precision STD care for women. There's some issues that I think are essential for us to do that. The first is improved diagnostics, and so that's where I think that this work, I think, is moving. Then there are novel therapeutics. We've already heard people, two speakers before you, talk about what's happening with that, how we're running out of antibiotics. Sphingobocin from the CDC in 2011 on a Frontline special was very clear to the public that we are now at the end of antibiotics, and that was 7 years ago. And the reality is, while people really focused on people having strep infections, those of us who take care of people who have STDs, that was code word for us that we need to get on top of our game. Then there's the issue of antibiotic stewardship. PID is syndromic management until proven otherwise. If we don't incorporate novel diagnostics, it's no different than if we were in places that didn't have it. Infection control is another issue. If we don't make things a public health control program, we don't report when people have illness, we'll never know how many people have it because, you know, these are really convenient samples that, you know, when I look at 700 women, it's not necessarily a population-based sample unless we're taking from the population. Behavioral intervention, research funding for that is somehow dwindling, and people are really focused on precision care, not so much for STDs, but for other kinds of things. I assert that it's not just for cancer, it is for our patients as well. And behavioral intervention for STDs is important. I think while the diagnostics and the therapeutics are important, if you can't get a patient to take it, it doesn't matter. And so I think all of these things are the stairway that will actually lead us to reduce STI disparities. While my population is very different in Baltimore, if you looked at the map, just say of chlamydia in the United States, it's all blue. Yes, my patients have problems in Baltimore, but they also have problems in big states, Texas, California. Those states are blue too. And so for us, really thinking about young people is really what's important. So we've also participated, our research is being used now from our patients to even look at signatures that can aid in endometritis, and so they're trying to develop a novel test. But this is really chlamydia focused, and so I saw it the other day, and Charlotte and I were so excited about it, but the reality is that it's not really going to affect our patients if they have these other STIs that are lingering, because it's based on the load of chlamydia more than anything else. And so one of the things we've done now is we've developed a precision approach to management of pelvic inflammatory disease. So we've taken the tech and intervention and we've made it more specific to our patients. So we're doing basically the same study, except we believe that with an 86-fold increase in delivery of care, that should be standard of care for patients. We're actually enrolling everybody in TechN, but a subgroup will have precision nursing. They'll be assigned a nurse practitioner who will totally manage their care from beginning to end. We have the Johns Hopkins STD Research Laboratory run by my colleague Charlotte Gatos here, who will work with us to make sure we get those tests back. And so when we get those test results, we can actually go back out to the patient and we are going to actually treat them and see how that affects them over time. The cool thing is that we have developed this partnership with SpeeDx so that we can actually use that resistance testing to better prescribe when the nurse practitioner goes out. And I think that that's really important, because drugs that I used to spend $3 for a 14-day supply of are now tenfold that. And so the cost of actually delivering STD care has increased tremendously. And being able to be cost effective while also very specific for the patient is critically important. And then our goal is to see whether or not only can we reduce STIs, which we know we can, that we'll also decrease inflammation in the vagina, and that maybe we can change some of those community state properties and shift it to one that is more protective for our patients in urban America. I'll just say, though, that our last line of defense right now are condoms, and we can see that it protects in terms of vaginal dysbiosis. And so we'll continue to use programs that I think work for our population in Baltimore. The reality is we don't talk about it very much, but the data actually show that for people who are worried about STIs and pregnancy, they're much more likely to have orgasm. If you can see here, both the female and the male partner. So we're getting to helping people have good sex and healthy sex that's safe. We're also trying to work with partners to help young people stay healthy. This is another study that we have called the Sexperience Study, and Dr. Matson here is one of my colleagues on this particular study. And we're trying to work with young people who have been exposed, at least one of them who has had an STI, to really use transformational motivation to really shift their thinking about STDs. So for me, what's exciting about our work is really it captures the innovation of person-based communication and technology using community health nursing. It incorporates new STI diagnostics to improve precision of the PID diagnosis. We have identified a potential opportunity to really address vaginal microbiota in women facing STI disparities, and we're using transformational motivation as an untapped resource for precision care and to improve the relationship and sex experience for young dyads. And that's it. Thank you so much.